And I unfortunately will let you know that this was the version before the final version. It just got on here. There were more questions. I know that that was kind of the interaction. There wasn't any difference in information, but there was a few more questions in there for you. Challenge you. Yeah?
Does the treatment affect the parathyroids?
The treatment does it? No. We don't really see that in terms of them becoming hypocalcemic and hyperparathyroid. But a lot of them start with hyperparathyroidism. But I've never had a case where their ionized calcium comes back on future blood work low. However, thyroid carcinomas, you can see hyperthyroidism and hyperparathyroidism because the tissue is just stimulating the whole thing. And yeah, and you will see that. I have seen one case where they have carcinoma, and they have both.
You did a CAP for me.
Keep the lights.
You did a CAP for me in January, and the 30-day V1 was fine, but the 60-day started going up, the 90-day went up, and then it stabilized.
Was the T4 low?
At 30, yes, it was hypo, but then it stabilized into a nice 1.2, I think, at 60 days.
Exactly. So what we're talking about with the GFR is it's a euthyroid state. So that really brings home that point of if the GFR is low, I'm sorry, the thyroid is hypothyroid, that GFR is dropping, which is going to affect those kidneys. Once the euthyroid state comes back, the GFR increases, the renal values normalize. That's why I don't let these cats stay with a low thyroid, because a chronically low GFR, which is a chronically low blood flow to the kidneys, means progression of renal disease. I think that's what went on there. Anything else?
Dosage differently for the T4 values, like methimazole, higher dosage for higher people?
Yeah, I think that what you'll find is that when you start out with that dose, the low dose, on the higher T4s, you're not going to be able to control it. So you have to actually keep up in the dose. There's clearly an association between the dose necessary for methimazole and the T4 level. And so the higher the T4, you have to end up taking it up. Does that answer that? Because a lot of times we end up getting these cats that come in and we say, do the tapazole trial, and they start at a low dose, but the T4 was really high. And so it doesn't touch it. So they go month after month after month upping the dose to try and get it to where the T4 starts coming down. And it's a tough chase because the longer you have methimazole, the bigger the thyroid gets. And so you end up trying to chase after it because after 2 years or so, your methimazole dose is a lot higher than when it started. Yeah?
Again, Vulcan and methimazole together without radiation therapy, would that be a good plan for people who cannot afford?
Well, I can tell you that the bulk can be good for looking for carcinoma, but if you can't treat, if you can take out some of that overactive tissue, it's gonna help. It has to help because the T4, the more tissue you have, the higher the T4, the more thyroid hormone it's going to produce. It's autonomously functioning. So if you cannot control this cat at all with methimazole, then taking some of that tissue out should help. Especially now in the economy, it's tough. What do you do for that?
That's the point.
Yeah. If that happens and you got a really good owner, just call us and we'll try and help you out.
Okay.
Is there an upper age limit that will start having problems with the I-131 treatment with all the ups and downs? I know ultimately it's an 18-year-old cat. It's probably not going to last 2 years whether you treat it or not. But with all the rapid changes that are happening, is there an age limit that seems that they have more troubles than not?
I would actually say it's the bigger thyroids that have more troubles.
The
bigger thyroids. I've seen more problems with huge thyroids, even in a 13-year-old cat, than I've seen in an 18-year-old cat with just a small thyroid because of the rapid shift in the homeostasis and the side effects to that. The only thing I have to do here is actually, if you bear with me, I have to end this thing because the end assessment wasn't in there because there's a part there I want to get your feedback on everything, so I'm sorry. Kim, do you have something you want to say?
Thanks for coming.
Don't let them go yet.
Delicious. I learned a lot about hypothyroidism and the cat.
I just want it. Oh, that's a good question. Hold on. All right, so on the phones, actually, it should have a thing that says that everything's ended, and then a survey to rate the presentation, and you'll get your results emailed to you, how you did on that. But I more importantly want to know how I did. So fill that out, please. How much is it? It's $1,100 for the exam here, and then the thyroid scan, the cardiac ultrasound, the treatment, and the boarding. And anything else that we have to do, we always talk with the vets and say, hey, you know what? This animal really is pretty debilitated. It needs an esophagostomy tube, like the one we put in. We charge $300 to put that in. Everything that we do, we try and have you all do to keep that association. We're really here to just do the treatment, but we want to make sure that things are going to go well.
Do you anesthetize them for the scan?
No. Some states require that, but California doesn't. And Dion's exposure levels through the roof.
The one thing I was going to add as far as the sedation goes, if you guys do have a client that has a fractious I-131 injection, they normally receive a really small dose IV of propofol, so that way we can minimize any potential spill of the isotope. So obviously radiation safety is really important, and making sure the cat gets the entire dose. So that's maybe 5% of cats. We try to do it less is more, but if we have to, we can.
Thanks. Yeah.
Within the capital, is there a specific T4 level that you would feel that you're aiming for that may protect the kidney and may still keep the hypothyroid thing?
I
Like
actually lower.
You're just giving capital and anything less than whatever is good. You know,
Yep.
Is there an ideal number?
Yeah, I would say that on an older cat, which most of these are, I would try and get into that level that you see naturally, which is the lower 2/3. To get them just into the normal range probably is still causing a little bit of the excess function on the kidneys. They're running a little bit hot, but the beauty of tapazole, which you can do it with after I-131 therapy, but the beauty of tapazole is you can adjust that dose. So kidney values start creeping up a little bit, cat's PUPD, you can kind of back off on the tapazole. On the other hand, if you do I-131, the cat's low, cat's PUPD showing signs, then you have to do your fluids and you can actually supplement. You can get the same effect by supplementing with siloxane a little bit. It's not really what I like to do, but if you get into a place where you're kind of between a rock and a hard place, then you try and push the kidneys a little bit more.
When you supplement with siloxane, is that short term just until it comes back up, or is it long term for those cats?
Well, it depends. So what we do is if at 6 months they're still low, we'll actually say put them on for 5 months, take them off for a month, and then recheck at 12 months. And at that point, if they're still low, for life. I've really become a firm believer in siloxane, and less than I was before. I used to think, oh, well, they're not fat, they're not having a greasy hair coat. Hypothyroidism is bad. Well, I'd say when we first started, yeah, but now we talk to them about all that. That's the big thing, is that as long as they understand all that, and there's a lot to go over, but as long as we're clear with them about this, if this, then that, they're all usually really, really good. They understand that. Yeah?
I could use a little more help, guidance in terms of decision making about who are good candidates when there's suspicion of concurrent renal disease. Where you mentioned that if they're already PUPD and having gross signs of renal disease, it's going to be 2 years no matter what, so there's no point in treatment. But a little bit more, do you have a little bit more, like? Yeah. Okay.
Yeah, the talk with the owners what their expectation is, okay. All right? You got to find out how much, first off, if the cat cannot take tapazole, then that's their only choice, all right? So those always talk to them about treatment, but understand they have to treat afterwards. The next one is the owners are, do you want to pill this cat every day? If that's the big reason that they want to do it, then understand that afterwards you're going to do fluids. Somewhere around 35, 40 on a 35 on a BUN, 40 on a BUN prior to, they're going to jump into the 50s, all right? And when they hit about 60 is when they start to be clinical with their PUPD. So give it about 10 or 15 points on the BUN after treatment, and even more if they go hypothyroid permanently. And then around 60 is when they start to be clinical. All right? Does that kind of help?
So if they're already at 45,
they're going to be clinical.
Okay.
Well,
So at that point, you'd have the 2 years kind of
yep.
regard.
And we would also talk about doing a lower dosage, 3, to not knock it back all the way. So we do, and we don't. But that's voodoo. That's we cut the head off the chicken and let it run around and see where it lands. Sorry, I just watched they just had a TV show with that South Park. Sorry, bad humor, but it really is. It's kind of a voodoo thing in terms of because no one has that optimal dose, but we know that for millicuries, we have a chance of the permanent hypothyroidism. We might back off, do a little dance hope.
Your specific gravity of 1045, probably okay.
Yeah, I haven't seen one of them have problems afterwards above 1045.
Okay, so you can use the specific gravity in the BUN
Yeah.
to kind of decide. Okay.
Yeah, but yeah, give it about 10 to 15 BUM points. It's usually what they end up going up in the clinical. Yeah.
What is the youngest cat or age of the cat? The youngest one that you have treated for?
I think ours is 8, but in the literature they've actually had congenital or juvenile. We have a lower one, 3?
We have 5-year-olds.
5-year-old?
I know we have 6.
5. They know. So, but there are ones that are 1 year of age, and it's a congenital hyperthyroidism with an overactive thyroid gland.
More likely to be a carcinoma for the
No,
No.
no, it's just some weird pituitary thing, TSH secretion, or primary thyroid disease that's been reported. Anything else? Did I answer your questions? You can always call us. Where's Dr. Garcia?
He's actually not here right now.
You call and Dr. Garcia, talk to, yeah, if Dr. Garcia doesn't know what, he's the intern. Every year we have an intern and they go on to do a residency. He's this year's intern, great guy. But if he has any questions, he'll come talk to me. If I don't know the answer, which is quite often actually, I will look it up or I'll go talk to other people. So, anything else? Thank you.